afternoon and welcome to OLLI at Cal State Fullerton. My name is Ellie Monroe and I, along with James Monroe and Bob Newcomb, will be your co-host for today. Today we have Dr. Cesario, who will be returning back to OLLI to update us on the latest information on the COVID-19 crises. Dr. Cesario retired from UC Irvine, in which he served as the Dean of the School of Medicine for many years. His specialty is in infectious diseases.
Okay, go ahead.
Okay, so today we're going to talk about coronaviruses, and we'll talk about what's happened since we first really became aware of this virus and what it's doing to people. So I'm not going to review all of the historical features. Just want to point out that we've really known about this virus really since January, and probably the first case actually had occurred in November as far as we know. We don't know where it came from in nature, but we know this is a bat virus. It is not a particularly unique virus. It is a virus that has the same characteristics of many viruses, so that it doesn't have any particular dimensions that would make it unusually aggressive, other than for the fact that it's new to us as humans, so that it spreads readily to a population that is susceptible to it. I always like to point out the virus composed of, essentially, you can think of as three components. The protein components, which are the structural components that give it its shape. The functional components, which are the components that allow the virus to reproduce itself. And the genetic components, in this case, RNA, that are the blueprint for future viruses. The structural proteins that I want to point out are four. The spike, which is what allows the virus to attach. Think of it like Velcro, so that the surface of the virus is studded with something that's like the spikes of Velcro. And when it attaches to a specific receptor, just like Velcro does, it's able to initiate the process of invading the cell and beginning to reproduce itself. The spike protein is especially important to us because antibodies directed against that protein are able to neutralize the virus. And also we know that cellular immunity also is directed against that spike protein. The matrix protein is a protein internal to the virus. The nucleocapsid protein surrounds the genetic material RNA to protect it, and the envelope is the outer waxy surface of the virus. I told you before about how the virus reproduces itself. Remember that in nature, viruses, unlike bacteria, cannot grow in artificial medium. They can only grow in cells. So the virus has to attach itself and begin the process of invading the cell, releasing its genetic material, copying its genetic material, using that as a blueprint to copy the various proteins we've talked about, and then incorporating all these into a new virus particle that's released into the environment to invade and infect the next cell. We know that this virus is a pretty stable virus, probably a lot more stable than influenza is. People have worried about, is this virus changing in nature? But actually it changes very slowly. The virus has 30,000 nucleic acid pairs. Of those 30,000, only about 2 change a month. Most of the changes are unimportant. It's sort of like, think of hair. Got all this hair on your head, and if a couple hairs turn gray, nobody's going to notice it. And that's kind of what happens to this virus. Most of these changes are basically changes that don't interfere with the function of the virus. There are a couple that we have known. The most important one is a small substitution in one of those nucleic acid pairs that seems to make the virus a little more easily attached to the host cell. We don't really know if it has any clinical implications, but in tissue culture, we know that that is the case. So the question is, how much virus do you have to be exposed to get sick? Well, we know with the original SARS virus, it's probably a few hundred virus particles. The cousin, Middle East respiratory syndrome, the camel virus, probably takes 1,000 or more. We don't actually know for this particular one how many virus particles you have to breathe in order to get infected, but we assume it's probably similar to SARS, what I call SARS-1, the original SARS-CoV virus. So probably in the range of a few hundred virus particles is what's necessary to get infected. And I want to have you keep that in mind, because you think of that, to get infected, you have to breathe in a few hundred virus particles. What is that dependent on? That's dependent upon how many of the particles that you breathe in when a person coughs or sneezes. It's dependent upon how many viruses are within those particles. We know in the case of influenza, that's 100 to 1,000 virus particles within each of those droplets. We don't know how much it is for this virus, but we assume it's probably, I assume it's probably in the same range. The corollary to that means that in order to get that number of particles into you depends upon how far these particles are propelled once the person talks, sneezes, coughs, laughs, sings. Also depends upon how far you are away from that person. It depends upon how long you've been breathing those particles in, and it certainly depends upon what you've done to protect yourself. Next slide. This goes to show you that when a person coughs, sneezes, talks, sings, they expel a number of these tiny little water-filled droplets into the environment. Now, they're not like all marbles rolling across a Chinese checkerboard where there's a bunch of holes, and as they cross the holes, they all fall in. They are a mixture of sizes, mixture of proportions, mixture of amount of moisture they contain. So they travel for various distances depending upon all those factors. We tend to think that most people get infected with particles that are 5 microns or larger. That's the basis for our saying 6 feet away should protect you. But in fact, there is a range of these things that are extruded into the environment when you do one of those things like coughing. And they travel for various distances, and they can stay suspended in the air for different periods of time. So we know that, again, all those factors that dictate whether you get infected are related to these simple factors here. How many particles are expelled, how far they travel, how long they remain in the air. Next slide. So the next slide says that most of the time we are infected by particles that are 5 microns or larger. At least that's what we think. This is constantly a subject of debate. Is it possible that we're affected by aerosols, meaning some of these particles dry out? And if they dry out, they can remain suspended in the air for longer, and they can travel farther. There's a beginning belief that probably that may happen more than we had originally thought, but we're still working on the research necessary to determine exactly what happens when a person gets infected. Based upon the droplets, we say 6 feet or more should allow you to remain outside the range, which you're likely to be infected. And we do know from general purposes that this is not a particularly durable virus that's inactivated easily by alcohol, hydrogen peroxide, and most effectively by dilute bleach. 5 tablespoons in a gallon of water is very effective at destroying this virus. But simple soap and water is very effective at killing the virus. We do know the virus can last on surfaces, depending upon what the nature of the surface is, for 3 or more days. Cardboard, stainless steel seem to be the surfaces that allow the virus to survive for the longest period of time. Other surfaces, perhaps things like wood, may be less apt to support the virus. Plastic may be another thing. Certain forms of plastic may allow the virus to last for longer. So those are circumstances where we worry that live virus can be present on the surfaces. Somebody touching those surfaces could pick the virus up on their hands and in so doing infect themselves. Next slide. What And how does this correlate with what we know clinically? And we're talking now about getting those virus particles in. People get those particles in. How infectious are they? So we have some clues. We say for every person who gets infected, there on the average is going to be somewhere between 1 and 3.5 new people infected by that person. It averages out to about 2.5 people for every person infected. But think of that as a chain. One person affects 2.5 people. Those 2.5 affect another 2.5, and it keeps going like that. So it's a big cycle. So one person can actually end up infecting indirectly a lot of other people. So if you live in a house with somebody who's infected, which should be the greatest chance of exposure, what's the chance you're going to get infected? And generally it's in the range of 10 to 15%. But I point out that we determine that by measuring active or remnants of the virus in your system. So if you do that test too early or too late, you will miss it. If you were to determine that by accurate antibody tests, it might be different. And I think it's probably higher than this, or we'll find it's higher than this when we actually get adequate antibody tests to determine who in the household is infected. But in general, we can say if you live in the house of somebody who has this virus and you're not protecting yourself, there's about a 15% chance that you are going to be infected yourself. If you don't live in the house, but you're a close contact of that person, meaning you work close to them, that chance is cut by about 1/3. So it's roughly about 10%. We know in the hospitals there are many people who have the potential to be infected, but we do know that those people, when they protect themselves in the hospital, can significantly reduce the chance they will get infected. And that's what's happened to us over time. We've learned how to protect our healthcare workers. Next slide. So the next slide shows how easily is a person able to transmit it if they get infected. And the reason we do this by age, because there has been a big controversy about whether young children are as infectious as adults. And what we think, based upon evidence that we have to date, largely from a study done in South Korea, is that young children, 0 to 9, as you can see here, in case of an individual of that age who got it, had contact with 57 other people, only 3 of them in the household living with that child ever got infected, for 5.6%. So that looks lower than the other percentages. But once they got to age 10, the percentage of contacts in the household who got infected looked very much like adults. So we now say, based upon this information and our generalized, the belief based upon information that we have, is that by the time you get to be 10 and older, you probably are as capable of transmitting the virus as easily as an adult. Under 10, you may be less able to transmit it. But this week, a new article came out saying that young children in their nose have as much or more virus than adults do. They may actually be expelling more virus because they may have more virus in the nose, which potentially could be a source of additional virus in the environment. But based upon this, we say very young children under 10 probably are less likely to transmit it. This has nothing to do with getting sick. It just says if they get sick, what is the likelihood they can transmit it to others within their household? Next slide. So these are the references for those cases that I just talked about. But I want to talk about a special event that we call super spreaders. And what I want to leave you in the back of your mind is that there are circumstances in which the virus is most easily spread. And there seem to be certain people who may be more capable of transmitting the virus, whether it's because they have more virus, whether it's because of something they do, cough more often, talk more loudly, sing a lot, that they seem to be able to infect other people more readily. So we call them super spreaders. And these are examples basically around meals that you can see where one person exposed 8 people, 8 got infected. Other cases where 47 people got exposed, an end sheet, 10 got infected. So there are circumstances where people got exposed and a higher percentage got infected than we would have thought. So we call them super spreaders. There are some very unique situations down here at the bottom. There was a choir practice in Skagit Valley, Washington, where one individual came in and during a 2-hour course of choir practice seems to have infected 58 out of 61 people. Why? Because the environment where you're most apt to catch the virus are small rooms where there's a lot of crowding and a lot of contact between people, and the ventilation is very poor. So when you have that combination of things, you are most likely to get infected. And so super spreaders in that kind of environment are capable of infecting more people than you would ordinarily have anticipated. Next slide. These are the references again for the transmission. Now, I've been talking to you about the situation in general in terms of how people are apt to get it, what it takes to get it. And so what I'd like to point out from the next slide now is the fact that even though we have calculated this data and the research has been done largely on people who got sick, it was when they got sick they were able to do the studies of how it was transmitted to others. But we've come to realize that a lot of people who are infectious don't realize it, either because they don't have symptoms at all and are never going to get it, or because they are in a phase 2 or 3 days before they actually get symptoms, and it's in that phase that they are actually transmitting the virus just as well as when they transmit it for the first few days after they get sick. So a very important part of understanding how this and why this virus is being transmitted in the community is an understanding that people who are not sick are capable of transmitting the virus in one of those circumstances. Either they're never going to get symptoms or they are in a pre-symptomatic stage. So we also know that when we start actually tracking people down who are sick, that they represent a fraction of all those who actually have been infected. And the best estimate is that for every person who we know of is infected, there are somewhere between 5 and 10 out there that we don't know about. So when we say there are close to 5 million people in the US that we know have been infected, 4.5 million to be exact, we can say, well, probably the actual number is not 5 million, it's probably closer to 25 or 30 million that are out there that have actually been infected. Next slide. Now, we've talked about how easy it is to transmit the virus and what can go on. The key thing I want to emphasize is what can you do to protect yourself? And keep in mind, the idea here is not to breathe in those few hundred virus particles that are capable of infecting you. So the obvious thing is you stay far enough away from anybody else who is infected or who might be infected that those particles are not going to be inhaled by you. That's social distancing. Also, even if you're far enough or if you're not far enough, what can you do to block those particles from getting in your respiratory tract? And you can wear a mask. There is plenty of data, and I'm going to show you this next slide here to give you an example, that tell us that masks are effective in reducing the amount of virus that you breathe in. And I tell people, look, even if you haven't read this literature on how effective masks are, there is a very important tool that you have that will explain that masks are important. That tool is between your 2 ears. And between your 2 ears, you can reasonably rationalize that it is important to cover your respiratory surfaces to block those organisms from entering into your respiratory tract. We talked about touching, how the virus can last on surfaces. Definitely, if you cough, we want you to block the transmission, the expelling of those viruses into the environment. Cough, if you have to, into your arm. Cough with certainly covering your face with your handkerchief. Wear a mask, because the mask itself will block a lot of those particles from passing out into the environment to infect others. Now, once we know somebody's infected or we believe they've been exposed, we like to keep them away from anybody else to prevent others from getting infected. So that's what we call contact tracing. Anybody who's been exposed, we want them to quarantine so that they don't infect others before they become infectious. And that's the 14-day quarantine period. If a person does get infected, then we don't want them circulating until at least 10 days from the onset of symptoms and at least 3 days that they have been without fever in the absence of using drugs like aspirin. Next slide, please. In the hospital, we use these same techniques to prevent healthcare workers from getting infected. And even though we do this, people are infected. Usually, it appears that most healthcare workers infected actually are infected in the community. So we screen everybody who comes to work in the hospital to send them home if there are any signs of infection. But we do the same thing we've talked about. We protect ourselves against droplets, eye protection, masks, frequent hand washing. In certain cases, we use shields. And certainly if we're working around patients who are infected, we wear gowns and gloves. And if we are doing certain procedures, we have shields so that those particles are blocked, in addition to wearing a mask underneath that. Next slide. So these are the references to masks that I talked about. And this is just a sampling. The number 4 reference also talks about the importance of social distancing. We are pretty sure that using masks and social distancing have prevented a significant number of infections where they have been used. The problem we have is of convincing everybody to use them. And that's been a big difficulty for us in the US. Next slide. So now let's talk about, if you get this, how infectious are you? And the first question is, how much virus do you have and how much virus are you expelling? Well, the first experiments were all done using fragments of the viral genes, fragments of the viral RNA. Now, when you use that, you can't tell whether the virus is live or not. I say it's like somebody walking down a stairways with a tray of glasses made of crystal, and they stumble down the stairway and the glasses break. And then somebody comes in and says, gosh, I really want a glass of water. You can see broken glass, but the question is there going to be a glass in there that you can use to drink? So when you do this by detecting the viral RNA, you can say there are fragments of virus, but what you really can't tell is where any of those fragments representative of a virus that was living and capable of infecting others. So most of our studies are based upon that type of analysis, looking for the viral RNA. But what we have found from those studies is that the peak time of infectivity is from just before you got sick to a few days after you got sick. And that's what you can see here, is that the slide of all the different people here falls off pretty quickly about day 6 or 7 there. And then it lingers for a low period of time out to about 3 weeks. And then it pretty much goes away, although even then there are occasional people that you can affect the virus. You can detect the presence of the virus out for somewhere between 5.5 and 6 weeks. But the next slide is another way of looking at this. And that says the only way we can really tell that you're infectious is if we try to culture live virus. We got to grow it in a test tube. We want to grow it in tissue medium and find out if the virus is actually there. And there are only a few studies that have done this because it takes a special laboratory. You have to take special precautions because you don't want the technicians to get infected. So there are special circumstances where you do this, so there haven't been a lot of studies. But we have a handful, pretty much all listed here, from people who have grown the virus, from people who are infectious, from saliva, sputum, which seems to be, to me, the most infectious, one case urine, but also in a couple cases from stool. And what we have found in these circumstances, what's been found, not me, is that it seems as though you can detect the presence of live virus for about 10 or 11 days, maybe 12. So you are probably infectious for about that period of time, for about 10 days after you get sick. Virus has been present in the stool. We don't know whether or not that represents a way you can get infected, but since children do get diarrhea, we're thinking that it may be possible for children to be able to transmit the virus from contact with their stool, meaning dirty hands, pass it on to others, but that has yet not been proven. But it's considered an area for research. Next slide. So let's say you get the virus and now you get sick. What is going to happen to you? And the point that I want to make is, remember, when we talk about people who get sick, what we're really talking about is people who we know they got sick. And so all the data is prepared from studies on people who we know got sick. So there may be a lot of people out there, in fact, I told you somewhere between 5 and 10 for everyone we know got sick, are out there who never reported their symptoms. So they may be milder forms of this, and undoubtedly are. But our data is drawn from the people who sought medical attention, not from those who were asymptomatic. Next slide. So what happens if you do get sick? Well, it takes the virus on the average between 5 and 6 days to make you get sick. But there's actually a range. We say some people who got enough virus in the right circumstances might get sick within 2 days. And others who maybe got a very low concentration of the virus or for some reason had a very active immune system, that it took 2 weeks to get sick. So while we recognize that the average time to get sick, we call that the incubation period, is between 5 and 6 days, we say we consider the incubation period from 2 days, the time you had contact with the infection, until 14 days after. So that's the presumed incubation period, and that's the basis on which we quarantine people for 14 days. The people who we know we got sick have 3 major signs and symptoms that we say are a part of the constellation of symptoms that represent this disease. Most of them have had fever. Most of them have had cough. And again, we're talking about the sicker patients get some element of shortness of breath. But there are other things that go with it. Normal aches and pains that you experience when you're coming down with a respiratory illness, tiredness, sore throat, runny nose, and some unique things. A sizable number of these people seem for some reason to lose their sense of taste and smell. Whether that's unique to this or not, probably not, but it's a fairly common thing for people, particularly I would say younger people coming down with this, to lose the sense of smell and taste. It will come back as they recover, but it's so perceptible that they comment on it. Then we talked about this number who may have diarrhea or vomiting, but by and large, GI symptoms of that magnitude, diarrhea and vomiting, are not very common. Some people may lose their appetite, feel a little nauseated. That's a little higher percentage, but the number who get diarrhea and vomiting is relatively small compared to those who have fever, cough, and shortness of breath. Now, the next slide gives you a compilation of all of these symptoms and the frequency at which they found them. And this, again, is from a potpourri of different patients, but you can see fever, cough, or shortness of breath is found in at least 2/3 of these patients. It's closer to even to 3/4. And again, this depends upon the population that you sample. Those who are more sick are going to have more of these. less sick will have less of these, but you can go on down and see runny nose, sore throat, headache, fairly common with this, and smaller percent that get nausea, vomiting, or diarrhea, etc. Next slide. So the key part of this, if it gets in your respiratory tract, it gets into your lungs. Those receptors we talked about, the angiotensin converting enzyme receptors, are present all the way down in the bottom of your respiratory tract. So if the virus gets down there and causes inflammation, your lungs will try to wash it out, and your lungs then will fill with some degree of fluid and inflammatory cells that are there to kill the virus. And that's what we detect on X-ray. In most cases, you do an ordinary chest X-ray, and it looks pretty good. This X-ray here is one of the more advanced ones for a patient with this disease. But what you can see around the heart is that big white thing in the center, and the bottom of the X-ray is the top of the diaphragm. The lung itself should look pretty black. You see the ribs there coming out from around the heart there. The top part of the lung is the way lungs should look on an X-ray. Pretty much black with a little white. When you get down to the bottom, you see this white stringy stuff that looks to me like somebody making cotton candy. Have you ever seen the way cotton candy is spun out from the machine? You get these little strings. And that's how that's represented at the bottom of this X-ray. And what that is saying is the tiny little air passages have begun to get inflamed, and they're probably beginning to swell a little bit. Now, if you take this person and you do a CT scan, computerized axial tomography, you then get a more detailed, more accurate picture. Next slide. And on the next slide, you can see where the arrows are pointing, where the actual inflammation is in the lung. And on this, you can see it's pretty extensive. And you can see there's those little holes in the inflammation. That's what gives it the name of ground glass appearance. It looks like little ground glass. Those crystal cups that we were talking about before. And this is the sign of COVID pneumonia. This is oftentimes a more advanced stage, but we also recognize that sometimes even people who are not that symptomatic can have pneumonia and not be aware of it. Next slide, please. Now, we do know that there are certain risk factors that make it more likely that you get sick. What's the most important one? Age. The older you are, I'm going to show you this after a while, the more likely you are to have fatal consequences of this. And probably we could say the more likely you are to get seriously ill. But that's compounded by other factors. Heart disease, high blood pressure, diabetes, transplants, probably cancers, all make you more vulnerable. Plus probably other factors that we haven't defined yet that make you more vulnerable to getting sick with this. Next slide. So if we take all these patients who came to the hospital, this is from early studies, but still pretty much true today, we say about 3/4 of them will do okay. Now, mild disease means they may be on the ward with pneumonia, with a bad cough, but they don't end up having to be put in the intensive care, and they will go home okay. So 3/4 of them will be in the hospital. In the majority of cases, it takes about 2 weeks or a little longer for them to get over this acute phase. However, of those who get admitted to the hospital, 1/4 of them will have progressive deterioration in their ability to absorb oxygen. Their oxygen level will progressively fall, and in order to prevent them from dying, we put them in the ICU, and we try to force oxygen in their lung one way or another. Maybe it's with just a nasal tube, but oftentimes it doesn't work, and we have to put on a tightly fitting mask to try to force that oxygen down. And if that doesn't work, we put a tube down in the lung, and we seal it, and we force oxygen in through that tube. And occasionally that doesn't work. So you have to put those people on an artificial lung, which is sort of like a dialysis machine for the kidney patients. But in this case, it's a machine that's not flushing out the blood, it's adding oxygen to it. And we call that extracorporeal membrane oxygenator, which has the acronym of ECMO, 3%. However, what I want to point out is as you move down the list, more and more serious illness, your chance of surviving this starts to get lower and lower. If you get into the ICU, your chance of surviving is probably 75%. If you're getting into that category and you have to be intubated, your chance of leaving the hospital one way or another is maybe now 40 or 50%, partly because there's a mortality rate of about 25% or so, but partly because it's difficult when that tube is down to find a way to get the tube out, find a way of breathing on your own to replace that oxygen that you needed. Furthermore, we knew when you get that sick, that you're in the ICU and you're having to have oxygen supplied, other organs begin to suffer. The kidneys suffer, probably actually as much as a third, despite the 9% here. We know that some of those patients go into shock. We know that 10 to 20% of them will have some element of heart injury. You can detect that chemically. So when you get this sick, a lot of bad things happen. And this is due to an overwhelming inflammatory response that we are struggling to control. Next slide. And the next slide shows you the course. And what I want to point out in the green up there is that incubation period, roughly about 5 days. And then you get sick with the typical respiratory things, fever and cough. But along about the transition from the first to the second week comes that shortness of breath. And about the middle of the second week is when people who are going to get in trouble, we say crash. That means the bottom falls out, their oxygen levels fall, they have a potential to get into shock, and that's when bad things happen. So it's in that second week that there is crisis occurs if crisis is going to happen. Next slide. Now also, as you know, you get to the hospital, we do a lot of laboratory tests. We always measure blood counts. And the blood counts are red cells for anemia, white cells to test for inflammation. And in a lot of bacterial infections, the white cell count will go very high. That's how we could tell if you have strep or whether you have bacterial pneumonia. But in this condition, oftentimes the white cell counts are low, but particularly in a form of the white cells that we call lymphocytes, which are those cells that are charged to, are the major controlling cells, or at least one of the major types of cells that control the virus, are the lymphocytes. And these patients, particularly as they get sick, suffer from a lower number of those cells because they're probably, this is me now, they're probably being consumed in trying to fight the virus. But we also know it's common, particularly as oxygen levels go down, to have other signs of inflammation. We know that liver tests can become abnormal. As inflammation starts to proceed, probably in everybody who comes to the hospital, there is some inflammation, but those who get sicker tends to have higher levels of inflammation. And we can detect that sometime from detecting some of their blood clotting factors. That's what protime and D-dimers are ways of assessing some form of the clotting mechanism. And there are also ways that we know that chemicals are produced in the body correlate with inflammation. One of those is an iron-binding protein called ferritin. C-reactive protein is another one, and the third one is called procalcitonin. And you don't have to know what these are, but you have to know these are inflammatory markers that typically, as people get sick, not in all cases, but in many cases tend to get higher and higher as a signs that the inflammation is getting worse. Next slide. Now, we can measure that inflammation, besides the way I've talked about, by actually looking at correlations with the immune system. The immune system produces a number of molecules that basically are molecules that the immune system uses to communicate between its parts. We call them interleukins. So there are many of them. There are somewhere around 35 or 37 interleukins known, at least at the last count that I was aware. But we know several of them are particularly associated with inflammation. They include interleukin 6, interleukin 10 levels are high, and tumor necrosis factor alpha, which oftentimes these are higher in these patients. And then you can actually measure the immune cells, which go down. CD stands for cluster of differentiation, which is a marker on the surface of the cell. And CD4 cells are helper cells that help you to make antibody. And the CD8 cells are cytotoxic cells that kill and destroy cells that carry the virus, and so doing destroy the virus. Interferon is a natural body antiviral substance produced when the body sees the presence of the virus. And you can see here, at least initially, we know that the interfering producing cells actually go down. So these are markers in the clinic of the activity of the immune system. Next slide. So we've talked about children. Young children tend to be less ill for reasons we don't know. We think they get less inflammation, but they also have less receptors for the virus, and we think that may be a factor, but we don't know. But they do get fever, and they do get cough, and they do get infected. And there's a unique syndrome called the pediatric multisystem inflammatory syndrome, which is characterized by fever, rash, signs of inflammation in the mouth and the eyes, and a number of other things which has been described in children. And now in the US, we've had a little over 350 cases of this. It's a very severe. They often go into shock. They oftentimes end up in the ICU, but fortunately, by giving them gamma globulin and corticosteroids, cortisone, in a pharmacologic form, most of them do well. In fact, very few of them actually, I think we've had only a very small number of deaths. 99% of them do well. Next slide. So now I want to spend a time talking about diagnostic tests. We talked about transmission, infectivity, illness. How do we know that when you got sick that you got COVID? Well, most of the time, the currently available test is to measure those RNA fragments. And we talked about how the fact that they are present for usually about 20 days, most commonly present, easiest to find in about the first week after you get sick. But remember, they are the fragments. They don't tell you that the whole virus is there, and they are gone, so that you can measure them too early and too late, and you can miss them. In case then you would have a false positive. And the other thing is that because of the urgency of this pandemic, the government bypassed the normal ways that we validate a test. And they said, look, if you can develop your own test, just tell us that you have validated it and then go ahead and do it. But they didn't actually go ahead and say, well, we want to see your validation and we want to be able to certify it. So there's a lot of tests out there. 177 institutions have sent in the test, say, we did it, we know it's okay, but only 12 has the government actually authorized to say it's okay. But we think most of those are okay. We don't usually measure viral culture because it's difficult and to some extent dangerous. Next slide. Now there's another way you can tell if a person has ever been infected, but you can't tell when they were infected, and that's to measure their antibodies. And this is usually now a qualitative test. That is to say, you draw the person's blood and you measure whether antibodies are present, and it just tells you yes or no. Usually with antibody tests, we like to know how much antibody is there. But most of the current tests now, until one that was just released this last few days, only tell you yes or no. And these have been authorized to a large extent, about 29 of them. They tend to be fairly specific. That is, if you have a positive antibody test, you probably have antibodies. But there's probably at least a 10% false negative result. So you can have it and be missed. The other great debate, but the other fact is that if you get a positive antibody test, you cannot be sure you're immune. All you can say is you have been infected with the virus at some point in time, but it doesn't tell you you are now immune. I think there'll be tests in the future where we may be able to do that, but the tests we have today do not tell you you're immune. Next slide. So the next slide, just to show you of when we talk about the immune system, we look at antibodies and cells, but it's a very complex system, and looking at those two little components is just a way of getting a little glimmer of what's happening. because it's a far more complex system. That's the point I'm trying to get across with this slide. Next slide. So the next slide tells you, again, what I've just told you about how immunity develops. And we do know with the vaccines that you can actually develop antibody, and we know this from natural disease, that will neutralize, and you can think of that as killing the virus. And we think the antibodies that do that are directed to that spike, and particularly the region of the spike that binds to the cell. It blocks that Velcro attachment. We know asymptomatic people also develop antibodies. And we know that besides antibody, there is a correlate cellular immune response, the CD4, CD8 cells. And generally, there's a correlation between the amount of antibodies and the amount of cellular immunity you develop. Next slide. That's the references for the immune system. Next slide. Now, common questions. I've had it once. Can I get it again? We don't know the answer to that. But so far in the US, we have never documented with certainty anybody who's gotten it twice. We do know that when you get antibodies, that you will develop antibodies universally after you get sick. There are exceptions to that, but those people who we can't measure antibodies, in many cases have evidence of cell-mediated immunity directed to the virus. We do know that that falls off within a short time after you recover. But we don't know that means you are less immune. All we know is that what we measure can drop off after you become clinically well. But we don't know that you can actually get a recurrent infection. That has not been documented here. Next slide. So the next slide is treatment. Now, in most cases, when we get people in the hospital, all we can do is support them. We give them IVs, we give them oxygen if they need it, we put them in the ICU if we have to, but we don't have an effective treatment for everybody. So we follow them along till we're making sure that they're okay, they're gonna be all right, then we send them home. So we give them respiratory care, in the worst cases, ICU, intubation, extracorporeal membrane oxygenators. However, next slide. We do have some good news. We know a drug that blocks the ability of the virus to copy its own RNA. It's an enzyme called an RNA-dependent RNA polymerase, can be blocked. It's something that the virus has that's a little different than what we have, and so we can treat it. And the drug remdesivir has been shown to have some clinical effect. How big is that clinical effect? It's not great. We know that people who get the drug tend to get better faster, tend to be better in 11 days. If they don't get it, they tend to get better in 15 days. Significant effect. They tend to have better mortality, 7 days, 7% versus 11%, but not a significant difference. However, Gilead, the manufacturer, now produced enough data that they say that there is an effect on mortality and a sizable effect that probably will be proven as we go along into the future. But the other problem with remdesivir is we don't have a lot of it. We don't have enough to give to everybody. It's produced in the largest amount possible, which is not enough to go around. So it's carefully selected of who's going to give it, and you have to give it at the right time. If you give it to patients that are already in shock on extracorporeal membrane oxygenator, it's probably going to be too late. So you have to give it as they are beginning to get worse. And because it's in short supply, you can't give it to people who are doing well. So oftentimes, who gets it is determined by a committee, because the personal physician is oftentimes too bound up in the care of that patient to make what would be an objective decision. So committees decide who gets it. So another difficulty with a drug that we believe works. Now, the other thing we've learned is that if you see patients who are beginning to get short of breath because they have a lot of inflammation, you can give them a potent form of cortisone. And if you turn that inflammation off at the right time, you will improve their ability to survive this by about 1/3. So you will reduce mortality by 1/3 if you give them dexamethasone at the right point. So we have two things that work. Remdesivir, if you can get it for the right time, and cortisone for those people who are getting into respiratory distress. Next slide. Now, by the same token, however, there are other things we're working on. We think if we take plasma from somebody who has recovered and give it to ill people, that may turn things around. And there's good reason to think that's the case, but I don't know of any objective evidence. But we're doing that on the supposition that it does work and our knowledge from other diseases where it does work. So giving them plasma from somebody, which basically is the fluid component of your blood without the cells, to give it to somebody who is getting in trouble, giving them that plasma from somebody who has recovered will work. And so then the thought is, well, if you're giving that crude product, can we purify the good antibodies out of there and give them high concentrations of the good stuff? And that's what the pharmaceutical industry is trying to do. Eli Lilly, in concert with two different companies, has developed that type of antibodies that are synthetically produced in cells. We call them monoclonal antibodies. And Regeneron is a company that has an antibody cocktail, also intended for the same purposes. These are currently being tested. Next slide. And the next slide tells you other potential treatments. There are other antivirals. One that I thought we would hear a lot more about, but we haven't heard a lot about so far, called favipiravir, which is an anti-influenzal drug. As much as we wanted to believe it, hydroxychloroquine, from the best studies we have, does not work. And it does have some toxicity. There always have been one or two studies that say, oh, yes, it does, include a recent one. But if you look at those studies, they are not well done, and there are critical flaws. So the best studies we have, which are double-blinded studies, randomized, suggest that hydroxychloroquine in people does not work. We try to find other drugs that inhibit the ability of the virus to reproduce itself. And there's one trial of a combination of some of these things, lopinavir, ribavirin, and interferon, which was said to work, but it has not been reproduced. We're trying to find other ways of turning off the immune system, and so that you don't get that intense inflammation. That works with cortisone, but it has not worked with other agents so far. And we're trying to do studies with interferons, which are the natural body antiviral substances. And so far, we haven't been able to prove that giving them pharmacologically works either. Next slide. So the next slide is going to show you about a number of trials that are ongoing. There are about 1,500 trials that we know about. Actually, all in all, about 2,500 trials that are ongoing of some type of intervention. Many of these are duplicates. For example, there might be 50 studies that we're looking at azithromycin and hydroxychloroquine. But all in all, there are about 2,500 studies trying to find ways of beating the virus. And of this time, the only thing we know that works is remdesivir and hydrocortisone. Actually, it's a dexamethasone given at the right time. Dexamethasone is a potent form of hydrocortisone. Given at the right time makes a difference. And we believe that convalescent plasma will work. We haven't proven that yet. There's anecdotal stories that it does. Next slide. So the next slide I want to talk about is the vaccine. Where are we with the vaccine? Well, everybody's trying to develop a vaccine. 165 candidates that are out there. But as you can see, the number that actually have gone to clinical trials is reduced. About 18 are in phase 1, which means they are looking to see, if you give this vaccine, does it produce antibody and is it toxic? Phase 2 is a more extended study of basically the same thing, looking particularly for toxicity. If you give it to enough people, are there side effects with it? And does it produce an immune response? And phase 3 is you give it to a lot of people and see if it really does protect the general public from infection with this virus. There are 6 vaccines that are in phase 3 trials now, and one special circumstance. So let's go to the next slide. So what are these vaccines and how do they operate? Well, a number of them basically take the RNA of the virus, called messenger RNA, the blueprint to produce particularly the spike protein. And you give it to people in a way that is absorbed and is be taken up by the person's immune cells. And those immune cells then will begin to produce only that portion of the virus that's on the blueprint, which is the spike protein. And the hope is that if it continues to produce that spike protein, your body will recognize it and make antibody, and you will be protected. The Moderna vaccine, which is the one you've heard about the most, sponsored by our government and developed here largely through the offices of the FDA, through the NIH, is the one that's most advanced. But you can see a lot of the others are. The stars after that says these are the ones that are right now in phase 3 trials, just beginning to see whether they really work in people. So that's genetically based vaccines. You can do that with RNA, and a few number of patients you actually can do it with DNA. Next slide. The other kind of vaccines is viral vector vaccines. You take a live virus and you change it genetically so that it codes for one of these COVID virus vaccines, COVID virus proteins, I'm sorry. So you give it to people to fool the body into thinking that it's being infected with COVID or with the SARS virus, coronavirus, when it's actually being infected by something that's not going to make it sick. So that typically these are adenovirus vaccines, which are a normal respiratory virus that we all are exposed to, in many cases never get sick with it. And particularly you can take one, the one that I'm most excited about is Oxford AstraZeneca, which is actually a chimp adenovirus. So we don't get sick with it. But you take that chimp adenovirus and you make it look like it's the coronavirus by making it covered with coronavirus spike protein, which then the body starts to react to. And you can see 2 of these are already in phase 3. The CanSino product has already been licensed in China for use in the Chinese military only. And actually the Russian vaccine was licensed this week in Russia, but they have never released the data on its efficacy or its toxicity. They just said to the Russians, you can use it. And anybody else who wants it can use it, but we don't have any facts about it. Next slide. So there's genetic vaccines, they're modified viruses, and you can purify the spike protein by a variety of ways and use that. Just give the spike protein. Have people make antibodies against the spike protein and have them, in so doing, induce an immune response that protects people. You can see there are a number of them that have used that strategy. Next slide. The other strategy that has been used is to take the whole virus and inactivate it. So you can chemically inactivate it or heat inactivate it and give people a dead virus, so to speak, and make them react to a dead virus. So that's been possible. So we will have a menu of vaccines, all produced by different ways. Genetically encoded vaccines, modified virus vaccines, whole protein vaccines, inactivated vaccines. Which of those we will use, we don't know. How often we will have to do it, how long it will be good for, are all things we don't know yet. We are testing them now just to see, will they really work if we give them into a general population, will they be protected? We have good reason to think they will from the preliminary studies, but those studies are just beginning now. We think that these will be probably available, at least one of these or more, be available on or about the 1st of the year, but that will depend upon the results of these trials that are ongoing, and then we will have to be able to distribute them. So even if we say we have the vaccine, we have to find a way of getting it to people and getting it to enough people that we produce enough immunity to block the spread of the virus. So that's my story. So let's go and see how effective we are now. Next slide. So the next slide basically says, look, you know, we have been working with this virus, trying to control it, but the fact of the matter is we still have a lot of people who are being infected. In the US, we have about 1/4 of all the known infections of this virus in the world. Most of those most recently have been in Florida, Texas, California, and previously in New York. Those were the hot spots. But what I'm going to tell you is I believe that the virus is going to go up and down. Be hot in California, and maybe it'll quiet down a little bit, never goes away, and then it'll pop up someplace else, then another place. Then it will become back in California. And that's going to happen until we have adequate herd immunity to block this. Next slide. So the next slide says, how do we compare it to the rest of the world? We're in the world today close to 18 million people who have been infected with this. And as you can see, about a quarter of those infected are in the US. Other countries that are having a lot of problem now, Brazil, India, Russia. And in the past, we know that Italy, France, and Great Britain. Great Britain continues to have a lot of problem with this. All have had big problems with this. Many of those have controlled it. We have not. Next slide. The next slide is a little indication of deaths. And what you can see from this is that in New York, they had the highest proportion of deaths, but almost everybody has had some death with this. In the world, we have the 8th highest death rate of 132 countries. We, the most advanced country in the world, are 8th worst in the number of deaths that we've had per million people. Next slide. So the next slide says that, what about by age? And what you can see, and this is an older slide. We now know that we've had people even less than 9 years old who have died from this. But the greatest risk is as you get older. Once you start to get past 39, 40, then the mortality rate starts going up every year. And it's not like these bars. If you're infected at 40, you have one mortality rate. 41, it's going to be a little worse. 42, it's a little worse. So it keeps on going up like that. Next slide. So the next slide here, after we look at the mortality rate, is what about in the world? Who's got the most deaths? And you could see we have, followed by Brazil, surprisingly Mexico, and United Kingdom. And then all the rest of the countries after that. Now, many of those countries on that list that have had high death rates actually have more or less controlled the virus. We have not. Next slide. So the next slide goes to show you how we compare to other great crises in the world, and remind you that all those crises have ended. We are 6 months into this. So this slide of 116, now we're at close to 155,000 deaths in the US. So you can expect that this number continues to grow for at least 6 months to come. So you can see how it stacks up against other great crises in the world. Next slide. So the next slide tells you what the world has done and what we have done. You can see that the European Union has gone aggressively after this with a unified approach for the most part, unified within a country. Social distancing is important. Many of them universally wear masks, very good contact tracing, very good ways of quarantining, and they haven't stopped it, but they have controlled it. We thought we were getting better when it slowed down on the East Coast. Next slide. But you can actually see what's happened to us now. We in the United States have not controlled this because we don't have a will to control this. We don't have a will to control this virus because not everybody wants to use a mask. Not everybody wants to use social distancing. Not everybody wants to do all those things that are necessary to do it. We have the tools to control it. We have the ways to control it, but we have to be able to do those simple things, not complicated, not rocket science, distancing, mask. There are 3 things that the Japanese said that are important to them. And the Japanese have said that the 3 things that you have to remember, and I like these 3 things, is avoid crowded rooms, avoid close proximity to other people, and avoid actual contact with people. And if you can do that, in Japan, they all wear masks. It's pretty much universal. We have the potential to mitigate this virus. We may not stop it, but we can mitigate it. But that's my message. Next slide. So the last thing I want you to consider before we go on to questions is a little axiom that was developed here by Donald Watley that said, if it took click it or ticket to get people to wear a seatbelt, I wonder if mask it or casket will convince them to wear a mask.
Is using asthma steroids really effective, and when must they be administered in the progression of the disease to work?
There was a physician in Texas who was promoting asthma steroids. I would not encourage the use of those as a way of dealing with this virus, as it potentially has a way of making it worse. So the steroids have to be given in very high concentration by use of these very dose of a very potent steroids has to be given exactly at the right time to work. So I would not rely on asthma steroids.
I'm going to take the next one. It's from a couple of people actually. So how effective is wearing a face shield without also wearing a mask? And on a related note, is wearing a mask helpful to the person who is wearing it as well as to those around them, or is a mask used to protect just others?
Well, the data is that masks work both ways. It's particularly important for the person who's infected to wear it, but also the data suggests that if you wear it as a preventative, it also reduces your risk. So we want people to wear it for two reasons. Most importantly, we want them to wear it to protect themselves. But in case they get infected, we want them to wear it to protect others. But it seems from the data available that it works both ways, both for the person who's infected and for the person who is yet to be infected. Now, what about shields? Shields are an added dimension. They don't appear to replace the mask, though. There's a study that was done in Switzerland, actually about 2 weeks ago. It's actually an anecdote, where there were a group of people in a hotel, some of whom were wearing masks and some of whom were just wearing shields. And a number of those wearing shields got infected, but nobody wearing a mask got infected. So shields are an added dimension, encourage their use, but we don't want them to be used as a substitute to a mask.
Okay,
Several friends from different households meet for dinner at an outdoor restaurant. What are the implications and risks since they are not wearing masks while eating and drinking and will not be sitting 6 feet apart?
I believe that constitutes a significant risk. That's an environment where if you are exposed to the virus, you ran a substantial chance of acquiring it. So I, at this point, discourage that type of gathering.
Okay, from a question on what are fomites, and then do we have statistics on how many people have become infected from shared food and surfaces?
Fomites are inanimate objects that carry the virus. That would be tabletops, stethoscopes, that kind of thing. To date, we have no known cases of the virus being transmitted by food. I know no cases. I believe nobody does either.
How many people who are diligent in wearing a mask in public still got the virus?
We don't know the answer to that. We say the mask is a useful preventative. There's no guarantee it's going to stop everything, but we believe that it reduces the risk. That there will be enough protection that it will reduce the chance you're going to get infected. But I always tell people, there's always a chance, no matter what you do. You have to assume that the chance of getting the virus is never going to be zero. The question is, how close to zero can you get it? And that's where social distancing, masks, some cases eye protection, shields, all those help you reduce that risk.
Go ahead, Ellie.
Okay, I'll continue. Is it necessary to wear a mask when walking outside as long as you are stepping into the street to keep a reasonable social distancing?
Yeah, when you're outside and you're keeping reasonable social distancing, the risks get to be pretty low. And I can understand why not wearing a mask may be okay. I do wear it. I do wear a mask in those situations as much as a signal to everybody else, that I'm concerned and I don't want them to get close. But I do recognize that I do think when you're outside and you're maintaining a socially acceptable distance, which is, I like to say, more than 6 feet, then the risks are pretty low.
Okay. Are the antibody tests specific for COVID-2, or do they only show exposure to any or all coronaviruses?
No, the antibody test is specific to this virus, SARS-CoV-2.
Okay, on a related note, if you are IgM positive but IgG negative, do you have COVID antibodies?
That depends. The answer to that is we assume it does, but there's a lot of false positives with IgM alone. IgM is the early antibody. When you've been exposed, you will get antibody of the IgM type for a few weeks, and then it's replaced by IgG, which is the durable antibody that in many cases, many viruses will last for life. So it's a temporary thing. But it turns out that the IgM alone has a lot of false positives. So I would say if it's IgM alone, I don't know I would bank on that as evidence that you've been infected.
Should we keep dental appointments and or doctors for typical annual visits?
My feeling at this point is that I have been asking my patients to hold back on non-urgent appointments because of the contact that generally ensues. If, on the other hand, you have a problem that needs attention, then by all means do it. If something that's urgent, by all means do it. But be careful in the waiting room, wear your mask, maintain your distance from other patients, do that type of thing. And if it's not urgent and it's not a necessary appointment and you think you can reasonably delay it, I would consider that. And in the worst case scenario, ask your doctor whether you can delay it.
Okay.
Is the virus actually alive?
The virus is actually alive. Now, you know, it's definitely alive. But I want to point out something. When we think typically of alive, we think of something like a bacteria or like us that you can put on a plate and it will grow. Viruses in the environment by themselves cannot grow. They have to be introduced into a cell and they have to undertake the cellular machinery to produce new viruses. But just in the environment, like on a tabletop, they are not going to be able to grow on their own. They may stay viable, but they can't grow. Whereas bacteria, if they get adequate nutrients, the essential nutrients, can grow. So yes, we consider them living, but they are, in a sense, parasitic.
Question about handling of used masks. How often can you use them? And is it okay? I feel, okay, my husband brings masks in the home. I feel this is unsafe. Is it?
It depends on the mask. Many masks are usable, but you have to follow the instructions on the mask itself. My wife and I do reuse our own masks. Once they get frayed or they get wet, then they're no longer good. On the other hand, many masks are intended to be disposable and not used. And we suggest that those be discarded. So you have to know what kind of mask you're dealing with. Some masks are washable, and they tell you how to wash them. Now, because up until now, we've had a shortage of critical masks, in certain circumstances, we've encouraged in the hospital people to reuse their masks. But that depends on the mask, the nature of the mask, and you have to know what the instructions for that specific mask are.
I think you've answered this one, but in case you want to expand on it, is hydroxychloroquine a good option? I think you've answered that, but I don't know if you want to expand on that.
The only thing I would say is reauthorize again. To the best of our knowledge, the best studies that we have told us that the hydroxychloroquine does not work. That is, it's not effective as a treatment or a preventative in the right circumstances. There are studies that may still be ongoing. There's some studies that may be ongoing, but the best studies that we have today suggest it does not work.
Here's a challenge for you. If you were in charge of the country, how would you manage to mitigate the number of deaths without killing the economy?
Well, I tell people this. I don't believe we have to kill the economy, and I don't believe we have to stop the country. But everybody has to do all those things we knew about. We have to do a consistent message that masks are critical. They're not important, they're critical. Social distancing is critical. We want you to go back to work, but we want you to maintain your distance. We want you to be cognizant of the fact you should wear your mask. We want you to be careful of hand washing. We want you to stay home if you think you're sick. We want you to report it so they can do contact tracing. We want you to do all those things that we believe and know work. So if you do those things, then you can go back to work and earn a living. Now, there may be situations where there may be situations where the incidence of the virus is so high that in those situations, we may, in a limited way, have to close things down. But we're trying to avoid that so people can earn a living. But you cannot go back and assume that it's normal. You have to wear the mask. And there are certain things that you need to avoid. Crowded places, bars. Remember what I told you about? Close contacts, crowded rooms, touching people. Any of those circumstances, no matter where you are going to promote the spread of the virus. So if I was in charge, I would give a consistent message to everybody, get everybody on the same page and say, look, we want you to go back to work. We want you to go back to school. But the only way you can do it safely and the only way we can keep this country going is if you do those things I've told you. Because if you can't control this pandemic, you will never control the economy. There will be constant starts, stops, closures, this and that. Control the pandemic is the answer to controlling the economy. But yes, you can continue to work if you do what I told you.
Should I wear gloves when I'm shopping in the grocery store?
I do. I think as long as you carefully wash your hands afterward, you probably accomplish most of what you have to accomplish. But it's the critical knowledge of what you're touching and whatnot that should guide you. I like to have the gloves on and wash my hands after I remove the gloves. But I think as a universal recommendation, one could debate that. But I personally think it's a good idea.
Doctor, I'm going to modify this question a little bit. What is your view on singing outside 6 feet apart while wearing a mask in a group? And also, what about playing instruments?
Well, I say in a group outside, I do think you're much better off. I think the chance of transmitting it is lower because the virus is going to be dispersed better. It's not going to hang around like it does in a closed room. In that singing in that environment, you may need to have a greater distance than 6 feet. I would tend to discourage it if I could avoid it. But if you can maintain enough distance, and quite honestly, I think you could sing with a mask on. A lot of people might disagree with me. I'm not a singer. But if you can sing with a mask on, all the better. Go back to what I said before. The idea is to reduce the risk. Reduce the risk by getting the number of virus particles into your system. So anything you can do to keep that number below a critical number, that keeps your risk low. So when you sit in an environment, whether you're singing or whatever you're doing, you have to say, am I in a situation where I am likely to get that critical number should one of my colleagues have it? And all these things propel the virus farther. Singing, loud talking, coughing, sneezing, those increase the distance and probably increase the time which the virus remains suspended. So if you have to, keep those things in mind. Always think in terms of that. What can I do to ensure that I am not breathing enough of those virus particles in? How far do I have to be away? How likely is it that person's got the virus? Now, what about musical instruments? Well, we don't have a lot of information about that. I don't know of any studies of musical instruments. I mentioned the other day to Ellie, there is a very famous story having to do with TB. TB is an airborne disease. We're beginning to think coronaviruses has a component where it may be airborne in certain situations. In that situation with TB, a trumpet player is known to have spread TB through the use of his trumpet, playing the trumpet, to a group of people who were around him listening to him play. So again, I think when you play a wind instrument, you have to be conscious of the fact you may be from pushing the virus out into the environment. If it's a string instrument or a piano, then I think the risks probably are no different than anybody else.
Okay, my friend must travel to the East Coast. Do you believe that it would be better to fly or drive? If driving, what do you recommend as precautions for staying in hotels?
It's kind of two ways. The problem with flying is that depends on the line that you use, airline that you use. But now many of the airlines are seating people right next to each other. So there's close proximity on the planes. I think they are requiring masks, but you have to also go through the airports. So in the crowded situation, there is a risk. I would say prefer driving, but when you drive across the country, you still got to stop in hotels, still got to stop to relieve yourself, still got to eat. So each of those situations, you're going to come in contact with people. Where do you think you can best control the number of virus particles you're getting in? You think you can better control it driving, better reduce your contact with people? Then that's the better answer for you. If you can't do that and your time on the plane is shorter, then you should consider that as an option. So you have to weigh it in terms of which way do you think you're going to have most contact with people?
On a related note, what are your thoughts about a family vacation with members from different households who get a COVID test within a few days?
The more people you get together, the more likely the virus is going to spread. And we certainly have had incidents where families have gotten together and spread the virus. So I would discourage family gatherings at this point in time, unless you can maintain distancing and masks, and also short period of time. When you all gather in the same house and you put different families together, probably increasing the risk significantly.
Okay.
And are any type of vitamins effective in treating?
No, we don't know of any vitamins that are effective as not effective treatments. We believe that good nutrition is always best for prevention of infection, by virtue of the fact that it probably contributes to your immune system. So we want you to have good nutrition, but beyond that, there is no evidence that the vitamins do anything else.
Okay, Dr. Cicera, I'd like to thank you. It is getting towards your time to leave, unfortunately. We appreciate you spending time with us and sharing this information with us. One of the things I would like everybody to know that this is being recorded. So if you missed any portion of it, or if your questions were actually answered in there, but you didn't get the gist of that, we will be posting the video for your view. And if you have any questions on how to get to the video, just send me an email and I will let you know.
So I'm going to leave you now to go on to my next talk, but thank you very much. And thank you, Ellie and Jim. I appreciate all of your help.